Good afternoon, everybody, and welcome to the MQ Health seminar series. And today we're going to cover a topic which is very relevant to all of us, which is making sense of COVID-19. Many of you I've met in person and some over links in the past. My name's Simon Willcock and I'm a GP and head of the General Practice and Wellbeing group here at MQ Health. First thing I'd like to do is to acknowledge on behalf of this gathering and recognising that we can be coming from many different parts of Australia. I'd like to acknowledge and thank the First Nations people of Australia and any elders who are here, past, present and emerging. The topics today, which we'll go through in a moment, but really they're going to help us to make some sense of the crazy world we've lived in for the last 18 months or so, and specifically for those in New South Wales and Victoria in recent months through extended periods of lockdown. It is an interesting time and a difficult time. We've been promoting what would normally be considered antisocial behaviours, avoiding each other, putting barriers between each other, making it hard to understand each other by wearing masks and keeping away from each other. And we've also made some what we would consider very normal behaviours illegal. So one of my elderly patients commented a few days ago that he never thought he'd see the day where it was illegal not to wear a mask when you went into a bank, for instance. And just as importantly, I think we've been banning or restricting a lot of culturally important community activities which bring us together as families, as communities at important times. I'm thinking of weddings and particularly funerals. We haven't been also able to visit our elderly people if they're in aged care facilities. So how do we manage that? Well, the speakers in the panel, who I'll introduce in a moment, are going to give their perspectives on that. That we're going to look at it from a population perspective, from community perspectives, and also from individual perspectives as well. And the panel we have today, and I'll say more about each of them as I introduce them. Professor Janaki Amin, first of all, is going to give you her perspective from the point of view of health systems and populations. Professor Sanjyot Vagholkar is going to talk about how this has impacted people in the community. And Professor Titov, who's the Executive Director of MindSpot, is going to talk to us specifically about the mental health effects of the crazy times we've been living in. So first of all, I'd like to, and it's important to remind you that we will have time for questions at the end of the presentations. We'll try to stick to time, so there will be 10 minutes or so for questions at that time. If you do have questions, and if you're using the Zoom function, you can post them on the chat space there, and there will be people who will be gathering and facilitating those questions. Our first speaker today is Professor Janaki Amin, who's head of the Department of Health Systems and Populations here at Macquarie University. She's the course director for the Master of Public Health, a very good and renowned course here at Macquarie University, and an infectious diseases epidemiologist working across clinical trials, cohort studies, and the analysis of routinely collected population data. So hugely important and relevant skills to the world we're living in at the moment. She has a particular interest in public health impact in priority population, and her major fields of research include data linkage studies examining morbidity and mortality in population-based cohorts of people with hepatitis B and C, and clinical trials and cohort studies of therapies for treatment of HIV, hepatitis C, and other sexually transmitted infections. And these studies have encompassed populations with poor access to therapeutics, people who inject drugs, and the LGBTQI+ community. So with no further ado, we'll hand to you, Janaki. Thank you.
Thank you, Simon. So we'll get straight into it. So what is public health? In these crazy times, we probably see that as an obvious question, with all of us having some understanding of what it means. But population health is very much about the health of large groups of people rather than individual people. In this instance, we're talking about the health of billions of people around the world, literally. So of course, I won't be able to cover all the aspects of the public health response and its impacts, but hopefully we'll give you some insights into the response that you've all been a part of. So public health response is broad and diverse. At its core, what we try to achieve is the protection, prevention, and promotion of health. With respect to COVID, these relate to what are the traditional pillars of infectious disease control that have been used throughout history, from the days of the plague to the control of cholera, TB, and influenza. The core practices of surveillance, contact tracing, modifying health behaviours, and managing the movements of people. How effective these strategies have been, how they are managed and optimised, then rely on the quality and access to relevant information, governance of responsibility and management of supply of resources, identifying and supporting those most at need and ensuring the capacity to deliver to all of those who need support. And all of these components, of course, influence each other in a complex system. And we need to have cohesion across that system for it to work well. In terms of the information that we need when considering how we're going to respond to a pandemic, information is not just about the numbers. It's about what we communicate, how we communicate it, and what we're trying to achieve. Part of the communication is about transparency so that we can build trust, so that when we ask populations to act in a particular way that is out of the normal, as Simon described earlier, that people understand why we are asking them to behave in this way and are more likely to be responsive. In this pandemic, we've had an explosion of the use of data in terms of and using public health terminology. This is what we call health literacy. We see data like these on our screens every day. So who the case numbers are, who's getting infected. We're thinking about things like hospital capacity in our everyday news reporting. We're hearing terminology like public health response. One of the key terms that we use in epidemiology, specifically related to infectious diseases, is R0. So this is a term some of you may have heard of in the last year and a half, which is a measure of how infectious a particular agent is. It's important to remember when we talk about R0, we're talking about how infectious or how many people will get an infection when there are no other health constraints. So when we're not doing anything to control the spread of the disease. The original strain of COVID-19 had an R0 of 3. So for each person infected, 3 subsequent people were infected. You've all now heard of the Delta strain, a new variant of the original virus. For now, the R0 for the Delta strain is 7. So for each person infected, we would expect 7 other people to become infected if there are no other constraints put on the spread of the infection. It's important to remember you've seen the enormous impact of COVID across our populations, but the R0, the actual infectious potential of this virus, is far lower than we've seen for measles and for mumps. And think about how well those diseases have now been controlled, largely through the experience of vaccination. The other number that we think of in terms of infectious diseases epidemiology is the RE, or the effective reproductive rate. So what happens to the spread of disease once we implement control measures? In this graph, you can see these data from New South Wales. This is our current outbreak. And the grey bars here show us the 5-day average of case numbers. Some of you probably been looking at this at 11 o'clock every morning. The blue line here is an effective R of 1. So when we get an effective R of 1, it means that each person is only transmitting to one other person. Intuitively, you can probably understand that if an R is less than 1, it means that the outbreak will diminish and eventually get to a level that we're no longer spreading infection. So in New South Wales, in the last 2 weeks, we have reached an effective R of less than 1. Our outbreak is starting to diminish. But in terms of those interventions, we need to think about who's calling the shots, who makes the decisions about which levers we should pull and when we should pull them. In Australia, we have a complexity in terms of the authority of who makes these decisions. Some of the decision-making happens at the federal government, others with the state government. Implementation is often managed by local health districts. We also have independent authorities such as the TGA and ATAGI who regulate devices, treatments, and vaccination. This figure is displayed just to show you some of the complexity that in terms of interventions over the last few months. It shows the national case numbers, the red being from New South Wales and the green from Victoria. And then each of the arrows and text are the public health measures. The black text indicates public health measures that are state-based, the red Commonwealth listing, and the blue is the Commonwealth vaccination programs. As you are well aware, these are just high-level interventions, and they change on a daily basis according to the underlying epidemiology. In particular, in New South Wales, you would have experienced that the response is modified and directed to particular populations at particular points in time based on the underlying epidemiology. In public health, this approach is underpinned by what we consider the determinants of health. That is, who is most at risk of the health outcome and why. And how are we going to design and deliver mitigation strategies to these populations? These strategies use a social equity lens. So we're thinking about negating detrimental systemic health and social impacts. This figure displays a range of factors that disproportionately exacerbate the impact of COVID. We've seen an increase in food insecurity, something we rarely talk about in Australian cities. And we've seen a reliance on the support from charities for food distribution. Impacts on jobs and the ability to work from home commonly impacts those in the lowest income brackets the most. Social isolation is something many of us have experienced, at least to some extent, and Professor Titov will be discussing this more in this seminar. One success story was the COVID homelessness strategy, which saw 400 people who were sleeping rough, that is sleeping on the streets, provided with accommodation. Unfortunately, though, the longer term impact of such positive strategies is not really known. 72% of the people who left that program are now in unknown housing outcomes. This is something I think we need to track into the future. We've seen many positive implementations of people who are in distress, but whether they will be continued to be supported after the primary effects of COVID have passed are yet to be determined. Access to vaccination has been another aspect of healthcare in which policy has prioritised specific risk groups. I'm sure most of you are aware that the initial government response was to roll out vaccination in phases. The initial phase focused on those most likely to be exposed to the infection, those working in quarantine, health, and in aged care. Then the most at risk of illness were targeted: the elderly, Aboriginal and Torres Strait Islander populations, and those with underlying medical conditions. The plan made sense, but we know that this plan on its own did not result in high uptake of vaccination in identified groups. The implementation of policy was in some places lacking. Once access to vaccination in the general population was improved, including through vaccination hubs, rollout through general practice and pharmacies, we've now seen one of the fastest rates of vaccine uptake in the world. However, some of our priority groups, as listed and targeted in these phased rollouts, still have the lowest coverage rate. At the outset of this pandemic and each wave subsequently, we've really been concerned with our capacity to be able to manage this pandemic. One of the key suppression measures that we've been talking about is this ability to flatten the curve. This figure is based on the modelling from the Doherty Institute from April last year. That was the first time we really started hearing about pandemic modelling in the general public. We've heard much about modelling since then, and very recently in terms to supporting the policy making of how we're going to manage the next phase of the pandemic. It's important to remember that these types of models are simplified. They allow us a tool to think about which levers can be pulled to best control an outbreak. They are limited by the evidence that we have to date. And while it might feel like we've been going through this pandemic forever, it's only been for 18 months. It's been a massive 18 months, but in the terms of science, epidemiology, and understanding how the disease works, our understanding is very limited and constantly being challenged, as we've seen by the arrival of the Delta variant. Long COVID is a phenomenon we've only been aware of since about the middle of last year, and it affects 5 to 20% of people with symptomatic infection. We don't know yet what the extended outcomes for people with long COVID are going to be and how much healthcare will be required to support them. We know that COVID has resulted in delays to accessing some routine healthcare, and Sanjyot will be talking about this a bit more as well. For example, breast screening in New South Wales was halted. It was announced yesterday that it's going to resume services. But the long-term effects of delays to healthcare are only starting to become evident. We were very concerned that there would be an excess of deaths related to restrictions to healthcare as a result of COVID control. And while last year we didn't see that, it's now emerging that we will see some excess in deaths related to cancer, dementia, and diabetes. However, as Simon mentioned as well, there have been some positive health outcomes related to COVID, particularly in relation to other infectious diseases. The most spoken about, which I'm sure you're aware of, is with relation to influenza. You can see here the peaks of influenza over the winter for the previous 5 years. The green line here is the average number of influenza notifications that we usually get. And it's in the tens of thousands that we usually see. For 2021, there were relatively few. And by that, I mean far fewer. We were seeing case numbers in the 20s rather than the 20,000s. So we've seen massive changes to our health systems. I think one of the key messages that has come home to me is the necessity to take health to the people. We've seen vaccine uptake and testing rates improve vastly when we've implemented hubs and suburban-based testing and healthcare. We're now talking about testing at home for COVID. Telehealth is another space that we've seen a lot of impact, and I think Sanjyot's going to talk about that as well. So I think to conclude this, this is just a snippet of some of the aspects of public health. Of course, it's a very large system that we're working with. In Australia, we've had some significant successes, some failures, and very many learnings. Hopefully, we'll have some time later to discuss those learnings. Thank you.
Thanks very much, Janaki. That's been a wonderful explanation of the terms that we've all seen thrown around in the media so much, and we have variable sort of understanding of. But thank you for beautifully articulating the journey of COVID since it arrived on the shores here more than 18 months ago now. So thank you very much for that.
Thanks, Simon.
As you've alluded to, the next speaker is my colleague Sanjyot Vagholkar, who's going to give some perspectives of how we're delivering care and the impacts on care as it's delivered in the community. Sanjyot's a colleague of mine at and currently discipline head of general practice at MQ Health. She enjoys providing comprehensive care to patients of all ages and is experienced of working with patients from diverse backgrounds. She's the conjoint associate professor with the Faculty of Medicine and Health and Human Sciences at Macquarie and the course convener for the Year 2 program Care. She has an extensive background as well as a clinical work, therefore, in both education and research, and involved currently in a number of primary care research programs. Thank you very much, Sanjyot.
Thanks, Simon. So I'm just going to share my screen and okay. So as Simon has mentioned, I'm a GP working here at MQ Health and lead up the clinic here. And I have to say that I think the title of the session, Making Sense of COVID-19, is an excellent title, because I think we've all spent the last 18 months really trying to make sense of things, whether we're healthcare providers or for you out in the community. And we've been overloaded with information and, overloaded by all the media coverage. There are days where you go home, you really just don't want to hear more about COVID, but, that's part of our life at the moment. So I'm going to try and keep it pretty simple and talk about the primary care response. When I say the word primary care, I'm talking more from a general practice perspective, but primary care does involve nurses, allied health, pharmacy. There's a whole gamut of people. So what has really been going on in the last 18 months in primary care? All right, so really this was a pretty unique situation for most of us who are current GPs, and there's no GP alive at the moment who would have been there back in 1918. So it's been a real sense of constant change for us. We're constantly having to kind of look at our policies, respond, do things pretty rapidly. And I think we've done a pretty good job. Now, one of the things I've written there, which was a little bit facetious, but I said policy by press conference. So for us in primary care, it has sometimes been that the information that's coming from, I guess, the Commonwealth and higher levels, sometimes we don't actually hear that until you hear it as well. And there literally have been days where I was doing a consult in the morning with a mother talking about a 15-year-old and their eligibility for vaccination, long consultation, because at that time it wasn't open to all children. And then literally 3 hours later, it was everyone 12 to 16 can get it. And so I could have saved myself about half an hour of talking if that policy had come through a little bit earlier. But that is the world that we live in. And GPs are pretty good at responding to that. So in 2020, in the early stages, we were really sort of working out policies about who do we screen, who do we have to let into the practice, or how do we screen people. And initially, as you will recall, that was often people that were coming in from overseas. That is clearly, panned out into a much wider sort of policy. We were also working out how do we deliver our services in general practice, because that has, that can be tricky, working out how you do that during lockdown and during outbreaks. 2021, the one word I would say is vaccination. I think if you had a sleeping GP and you said the word COVID, that would probably just be the reflex response, vaccination. We've spent a lot of time trying to work out how to deliver this in our practices. It involves a lot of working out, literally the flow. Where do you put the patients? How do you get them through? How do you do it safely? And now for GPs and practices in Sydney and Melbourne in particular, it's working out how we provide our clinical services in the setting of a Delta outbreak. So vaccination, which Janaki has touched on, the delivery of it, a lot of it has gone on in primary care. I just put these figures up. These were from the weekend, where you can see up the top, the sort of the total doses we've delivered in Australia, 26.4 million. And of that, just over 50% have been delivered in primary care, which is, predominantly in general practice, but now also in pharmacy, community pharmacy. And you can see at the state level down the bottom, there's probably been a bit more that's been delivered in the primary care sector. So general practice has been doing a lot of vaccination. And delivering vaccination is not just about one person, it's not just about the doctor. So this is just a photo of the friendly team that I work with. And yes, they are friendly. You can't see their lovely smiles because we're all masked up. But it is a team effort, and there's a lot more people that are involved in our vaccination than just the people in that picture. And look, I really want to shout out to our nurses out there. All our practice nurses in general practice have done an amazing job. And also, we really need our admin staff. So, if you know a medical receptionist, or you are one, or you're in your practice visiting your GP, give them a word of thanks, because they have had to field so many calls and have done a stellar job, and we could not do it without them. So I think it's really about a team working together when we're delivering vaccination. So vaccination is really our pathway forward. And people are probably well familiar with the fact that we've got 3 vaccines now that we're using: the Pfizer, the AstraZeneca, and the Moderna vaccines. They're all good vaccines. I want to keep this simple. We've had lots of different information about them, but from the perspective of a doctor, what I would say to you is they are all good vaccines at stopping you getting seriously ill, ending up in hospital, ending up in ICU. And that is why we want patients to have them. Now, I'd be the first to admit there was a lot of mixed messaging earlier in the year, the problems or the concerns about the rare side effect of clotting with the Astra vaccine. And that did fuel a lot of hesitancy, but I think we've moved beyond that. And just for a little bit of lightness, and I think we all need that, I had to smile when I saw this story a few months ago. So there's that picture I've got there in the slide. And that is Professor Sarah Gilbert, who was one of the lead people in the team that developed the AstraZeneca vaccine at Oxford. And she's there with her Barbie doll, because Barbie dolls, or Mattel, have made a Barbie doll in her honor, which I thought was lovely. And I did wonder about, wouldn't that be a great thing to put on your CV? But in all seriousness, vaccines are really our way forward. The vaccines have been through rigorous trials. So I think people's concerns that, somehow this was all rushed. Yes, they did do it rapidly, but that was because of urgency, but they did go through a rigorous process. So I think we're now at the stage where, certainly in urban areas, most people should be able to access vaccination without too much difficulty. There are some groups of people that perhaps are the more vulnerable that still are having a few problems. Now, I would acknowledge that in regional and rural settings, there may still be issues about access to vaccination. And obviously that's a little bit of an issue for when we start to reduce restrictions in a few weeks in New South Wales. And my last point there on that slide is really about, if you're feeling uncertain, you still haven't made that choice to have a vaccine, just bear in mind that viruses are pretty smart, and they will find the path of least resistance, and that is going to be people who aren't vaccinated. So, our strong advice would be, if you haven't been vaccinated, go out and get a vaccine. So what I wanted to talk a little bit about was actual sort of COVID management in the community. When you watch those 11 o'clock press conferences, if you're in New South Wales, or I think they're earlier in Victoria, they'll always tell you how many cases there are in the last 24 hours, and they'll talk about how many patients are in hospital or in ICU and ventilated, and all of that is incredibly important. And the care that's going on in hospital is obviously, critical. But what I wanted to highlight is that actually most COVID cases are not going to be hospitalised. So these figures were from the weekend, from Sunday. There were just over 11,000 cases in New South Wales that were considered active or in their isolation period. And of those, about 1,146 were hospitalised. So what you can see there is it's actually about 10% of people will get hospitalised. And so there's the other 90%, and I think sometimes we've forgotten about them because we're so kind of focused on the seriously ill, understandably. So what actually happens if you do get, you are a positive case for COVID? So currently, as I said, most of those cases will be managed in the community. And New South Wales Health, for example, and in other jurisdictions and other states, it would be similar, are kind of running what we call hospital in the home or a virtual hospital, where there's an electronic database of who are the patients that are out there in the community with COVID. They have contact, essentially probably via phone and video with medical personnel to monitor their status. You would go into isolation for a standard would be 14 days of isolation. It can sometimes be longer depending upon people's clinical state. And then once you've done your 14 days, you're actually discharged from that isolation, and you're then able to interact and go into the community as normal. And you don't need to actually be doing COVID swabs and showing that you're negative after you've had that isolation period. So early on, so if you go back to last year, we were sort of swabbing people madly when they'd had COVID to make sure they were negative before they could go anywhere. But that has actually changed, because your tests for COVID will actually show up positive often, weeks and sometimes even a few months after having had a COVID infection. So that's what you might expect to experience if you had COVID. What's it going to look like in the future? The reality is, when our restrictions lift, the cases of COVID in the community are going to go up. And so just based on the numbers that might occur, we would probably expect that it may not be possible for New South Wales Health, for example, to manage all those people in these virtual hospitals. And more of that care might start to shift out into GP. So it may actually be your own GP that looks after you. But look, this is very much at the moment being discussed and kind of worked out. But we would see that eventually this will be another respiratory virus that we manage in the community. And we're at that stage of trying to work out what that will look like. And then my last point there is, yes, there will be cases, more cases, but we would expect fewer hospitalizations. And we would expect that the cases, when they do occur in people who might be vaccinated, will be milder, or they may not even have symptoms. But unvaccinated people will still be very vulnerable. Just briefly, I wanted to talk about, well, are there any therapies? Is there anything you should take? At the moment, if you have COVID and you're one of those mild cases, you're sitting at home, it's essentially that you'll have symptomatic care, or what we call symptomatic care. If you had a fever, you would treat that. If you had pain, you can take paracetamol, ibuprofen, stay hydrated, rest, and of course you have to be isolated. The one drug that has recently become available is what we call a monoclonal antibody therapy. So it's an antibody that will bind to the virus and therefore stop the virus being able to kind of bind to other receptors in your body and multiply. And so that drug is sotrovimab. And this is being used early in disease, but only in certain patients. So people who are at higher risk, they might have chronic respiratory illness, they might have diabetes, older patients. And in particular, it would be used in the setting of someone who was unvaccinated, partially vaccinated. And the other group is people who might be immunosuppressed, or whose immune systems might be not working well because they're on medications to suppress them. So that group is a particularly vulnerable group. So if you were in a situation, the doctor monitoring you or looking after you might determine that you fit the criteria and would then, sort out for you to access that therapy. But the vast majority of people are not going to be having that therapy. There have obviously been lots of other therapeutic agents, or some that have had a lot of publicity, and I'm not going to start mentioning them. I'm sure people are familiar with them, but really you've got to look at the evidence and see, what really works. And we do actually have a national sort of task force that looks at the evidence constantly. It's constantly being updated. I've put in a link there to the website, and that has really, it's directed at healthcare workers, but anyone can look at that website, and there's certainly good information about some of those questions about other therapies that you might have some questions about. I think Janaki mentioned long COVID, where people get symptoms that go on for longer periods of time. And, a lot is still unknown about that. I think we're still really learning about it. So the group out at St. Vincent's Clinic and the Kirby Institute are doing a follow-up study of people who've had COVID, and I think that will provide us with good information. But what I would envisage is that these patients are going to be just like many of our other patients in general practice. They have a chronic disease, chronic symptoms, and we will be managing them in a sort of multidisciplinary way. They'll have their GP, they might be seeing a specialist, they might, often there's sort of mental health sequelae, and they might need psychologists and psychiatrists. So I think this is kind of watch this space. We will learn more about long COVID as we go. So I couldn't do this presentation without talking about telehealth. Telehealth has been a bit of a revolution, rapidly part of our day-to-day life in general practice. And we do that by telephone, we do that by video. And is it good? It's been great. It's been very helpful. There's lots of things we can do electronically, including scripts and referrals and talking to people. But there are still things where you will need to be seen face-to-face. And we, certainly in our practice, we feel quite strongly that there are situations where we need to see you for safe medical care. So what I would say to you is don't avoid a doctor's surgery if you really need to be seen. And certainly for some people, there may be issues around, if you don't have the technology at home or good internet access, we need to still be seeing you. Clearly, if GPs are going to be doing more of the COVID management, then we'll be using telehealth when people are in their isolation periods. So great to have telehealth. It's not necessarily going to completely take over all of general practice. And then lastly, I just wanted to touch on something that Janaki also mentioned, that we as general practitioners are worried that people may have been ignoring symptoms or not doing their usual preventive care, which was okay for a couple of months, early last year, but we're now 18 months in. We don't want people to be, not doing their usual cancer screening or checks for blood pressure or diabetes. So it's really important that you keep doing those things, because otherwise we will end up with sort of increases in the morbidity and mortality in those areas, which we don't want. And, the other concern is that people, a lot of non-emergency surgery has been put on hold. And so, that's creating a lot of anxiety and problems for people. And I think we've really highlighted that there are those more vulnerable groups, the age, people with disabilities that we need to be providing care for. So I guess, my take-home simple messages really is that, look, COVID-19 is here to stay. It's part of the spectrum of viruses we're going to be looking after. Vaccination is really, really important. And it's the way we can get to a sort of, new normal. And I said new normal because it's not going to be the old normal. It's going to be, we've got COVID, it's there, and we've got to learn to live with it. And look, primary care is delivering services a bit differently, but we're there. Please see your GP if you need to. Don't be afraid to seek care. Okay, thank you for giving me the opportunity to speak. I'm going to hand back to you, Simon.
Thanks so much, Sanjyot. That's been a wonderful perspective at the sort of coalface level as to how we've been coping with COVID in our Australian communities over the last year and a half. Now we're going to hear about some of the specific issues associated with some of the mental health effects with COVID. We're going to hear from Professor Titov. Nick's an accomplished leader in the field of digital mental health and has pioneered work in this field since 2006. Together with colleagues, he's conducted more than 80 clinical trials of digital mental health treatments. His research and clinical work is focused on developing strategies for reducing barriers to psychological treatments. And that was very relevant well before COVID, but even more so now. Nick's developed and led several digital mental health services and is the founding executive director of MindSpot, which many of you would be aware of. It's a national program based here at Macquarie University, and the program Ports, which is the practitioner online referral and treatment service. And his expertise is recognised and sort of internationally at this stage. Just to remind everybody as Nick loads his slides that please feel free to log your questions and we'll deal with them. I'll put them to the panel afterwards. But there's one here from Ed, Nick, that feeds well into your discussion. And Ed's question is, the WHO, World Health Organization, defines health as a state of complete positive physical, mental and social well-being, and not merely the absence of disease or infirmity. Now, this is definitely a tension that the management and prevention of COVID has thrown up for our community. So we're very interested to hear from you. Thank you.
Thanks very much, Simon. Well, hello, everybody. I hope you and your loved ones are all safe and well at this challenging time. Thanks very much for inviting me to speak. I'm delighted to be here. And I've really enjoyed hearing from Simon, Janaki and Sanjyot, and I thank them for their important observations. Now, my presentation is a little bit different. So I won't be talking about prevalence rates of mental illness or challenges in the mental health sector. I think those topics have been well covered in the mass media, albeit probably overstated in places. Instead, what I'd like to do is talk about what we can do each day to stay mentally healthy at this time. And this, of course, is important because of our unusual context. Now, as we all know, it's a time of uncertainty, a time of change, And we know that both uncertainty and change are challenging to deal with, particularly if they're chronic. But the good news, of course, is that there are practical things we can do each day to stay well. And a key message of my talk is that just like our physical health, we can do things to improve our psychological health. And my main message really about making sense of COVID moving forward is really emphasizing the everyday things that we can all do to really help our psychological health and stay resilient. Now, before talking about those things, what I'm going to do is just spend a couple of minutes very quickly talking about the key concepts of stress and resilience. And then I'm going to introduce 5 simple things that we can do to stay well. And to illustrate these, I'm going to provide examples from people who we've been working with at the MindSpot clinic and how they put these ideas and principles into practice. Now, by way of background, our MindSpot clinic is a digital mental health service which is currently serving about 30,000 Australians each year. And that's almost a 50% increase in demand from 18 months ago, which gives you a sense of the volume of people who are seeking care. So services like MindSpot have really been working at the forefront of a mental health response at a national level. And I want to acknowledge our team who've done an incredible job over the last 18 months in very difficult personal and professional circumstances. So a big thank you to them. And then moving through the talk, what I'd like to do is finish with a brief summary. Well, I'll try to summarize or synthesize the key points and then hand over to Simon for the question and answer part of our webinar. So what are stress and resilience? So we all know what stress and resilience are, but let me just go through some basic technical details. Stress is defined as our response to either a physical or a psychological demand or set of demands. It's a response which we make. Now, some stress is actually healthy. I know stress has had a particularly bad rap in the last year and a half or so, but we need a minimum amount of stress in our lives to stay motivated, active, and to pursue our goals. And most of us are resilient, and I think that's another key point I'd like to make. And we actually thrive under a moderate amount of stress. But if we have too little or too much stress, we can experience distress. Now, a good way to think about distress is think about what is our performance relative to levels of stress. And this figure here shows a graph, a famous graph, which describes the relationship between our performance on the Y or vertical axis and stress levels on the horizontal axis. And as we probably all recognize in our own day-to-day lives, if we have too little stress, too little demand, we're actually understimulated. We can become bored, we can become distressed. But as our stress levels rise, that is our need to respond, we start to move from feeling relaxed to actually thriving. Now, if stress levels continue to increase, of course, we become fatigued. And if they become excessive, we become overstimulated and eventually burn out. So there are risk factors at both ends of the continuum. And I think that that's quite relevant for people who've been in lockdown and experiencing restrictions. And of course, pandemics and lockdowns make us more vulnerable to distress. Now, resilience, on the other hand, refers to our ability to tolerate and bounce back from adversity, including too little or too much stress. And again, I think it's important to emphasize that most people are naturally resilient. And we all recognize characteristics of people who are resilient. They accept that life isn't always easy. For example, at the present time, they're often clear about monitoring their physical and psychological health and remaining active and engaged and adapting to the changing circumstances. They also tend to be honest with themselves, and they know when to reach out for support and help. And above all, they often remain realistically optimistic. Now, most of us, of course, strive to be resilient, and there are practical psychological skills that can help. And I'd like to share some of those now. Now, what I'd like to do is I'd like to just very briefly summarize 5 key actions or skills which are strongly related to psychological health. We've been conducting quite a lot of work in the last 18 months in particular, looking at what are the things that people can do each day to actually stay well. And there are things which people can do, which research shows that the more often they do them, there's a very strong relationship between doing these things and greater life satisfaction and lowering of symptoms, that is lowering of anxiety, depression, and distress. And these 5 domains, if you like, or actions and skills include practicing clear thinking, being involved in meaningful activities, maintaining healthy habits, maintaining social connections, and maintaining goals and plans. Now, the reality is we don't need to do all of them all the time, but the more we do these and the more frequently we do these, the better people feel. And what I'd like to do in the remainder of this presentation is just quickly run through these actions and provide some practical examples. Okay, so what are these 5 helpful actions and skills? The first one is practicing clear, realistic thinking. And this is important, of course, because it refers to our thoughts. And our thoughts, as we all know, affect how we feel and what we do. Our thoughts also affect our expectations about ourselves, the world, and the future. And we know that when people become stressed, too much stress or too little stress, we become more negative or prone to negative thoughts and feelings about ourselves, the world, and the future. So the key message here is to encourage people to check their thinking and expectations, to challenge unrealistic, unhelpful, negative thoughts and beliefs. And a key message, of course, is practicing self-compassion. This is one of the most important characteristics which defines resilience, is people actually being respectful of themselves. Now, what I'd like to do is in each of these sections is present some examples from people we've been working with through MindSpot. And every day we work with a very large number of people. People are engaged in treatment with us for 8 weeks at a time. And over the course of treatment, people share what changes they're making in their lives. We monitor symptoms and impact on people's lives and life satisfaction. And what I'd like to do is just share some of the observations that people make with respect to each of these 5 domains, including here the example of clear, realistic thinking. So these are what people are saying to us, and I think that these are fantastic observations. Many people have been reporting this observation here. To help clear their thinking, they've been turning off the news. Other people have been saying they've been giving themselves permission not to be perfect. Other people have reported that they've started meditating to wind down and practicing letting go of things that they can't change. Another person, in fact, quite a number of people have reported they're catching their self-critical thoughts, and those self-critical thoughts are often thoughts about not being good enough or skinny enough or smart enough. And reminding myself that I'm doing the best I can. So the take-home message here, the key message really is keep your thinking clear and realistic. That's one of the key things that you can practice to stay psychologically well at this challenging time. The second domain that I'd like to very briefly mention is engagement in meaningful activities. Now, meaningful and fun activities are those which give us satisfaction, joy, and pleasure. Now, the key point here, we probably recognize it all in our own lives, is that we tend to stop doing these things when we're distressed. So a simple question to ask yourself is, what are the things which stimulate and engage you, and what have you stopped doing recently? Now, again, going back to examples from MindSpot users, people are telling us that they're giving themselves permission, for example, 2 evenings per week to read and relax, booking movie nights and not feeling guilty. One person reported his wife and him are having home date nights each week. Now, this meme here is great. You can see on the left-hand column, list 1 is make a list of things that make you happy. On the right-hand column, list 2, make a list of things you do every day. And the message here is compare the lists and adjust accordingly. Other people reporting that they've started doing things which they'd stopped doing. And other people saying that they're giving permission to recharge each night by doing things which they enjoy, for example, playing the piano, enjoying a glass of wine. This is very simple, but it's really important, and most of us probably need to pay attention to it. So the key message here is plan to do at least one enjoyable and relaxing thing each day. The third domain I'd like to briefly mention is around healthy habits. And we know that we all have habits, whether we like it or not. The good news is we can choose whether our habits are healthy, neutral, or unhealthy. But we know that habits and routines can support our physical and psychological health. And these are things we do automatically. And the key question is, how healthy are your habits? Again, going back to examples from MindSpot users, a key habit which people have identified that they need to practice is starting to keep a regular bedtime waking routine, going to bed at the same time each night and waking up at the same time each morning. Other people reporting that they recognise that they fall into habits of eating too much or drinking too much, and they know they can engage in activities like July or October or whatever it might be to change those habits. Other people reporting that they've engaged in habits and picked up habits which are about helping define the barriers or boundaries between work and home. So before they start and finish work each day, going for a walk around the block. Other people reporting that that's to help manage their distress and symptoms of anxiety. When their phone rings or they get a video call, they've started to take 2 deep breaths before answering. Now, the key message here, of course, is very simple. There are the things we can do to build routine and structure in our lives, which are actually going to be beneficial for our psychological health, including the examples here. Going to bed at least early, at least 3 times each week, and making one healthy meal each day. The fourth domain is social connections, and we all know that connections are important because they help us feel bonded, affirmed, valued, and safe. They also support our confidence and our sense of resilience. And the key question here is, are you sufficiently connected? Again, some examples from MindSpot users I think are really important to illustrate the points. People saying that they've realised they've been avoiding family and friends and that they're changing that. That's a significant change that they've made to improve their psychological health. Other people reporting that they felt ashamed, they weren't coping, but they've reached out and they've been amazed at the response. And others reporting that they've reached out to friends and colleagues via SMS and again been surprised at the response. So a key message, of course, is to engage with our tribe. And finally, goals and plans. Now, goals and plans are really important and often overlooked, but they help us to look beyond the present challenges and see a better future. And so that's really about hope and optimism. And they help us to focus on what we can do to improve our lives. And the key question, of course, for yourselves is, what are our short and long-term goals? Again, going back to our examples, people reporting they're celebrating small wins, taking small and easy practical steps to achieving things, planning days and making plans for the week. And the key message here is to set basic daily and weekly goals. Okay, that's a lot of information. I'm going to synthesize and summarize and then hand across to Simon for some questions. Key points here is that some stress is healthy, but not too much. But there are things we can do each day to help us navigate and stay psychologically healthy and resilient in the coming months and years. And they include practicing clear thinking, meaningful activities, maintaining healthy habits and social connections, and maintaining goals and plans. Key messages is look after psychological health by combining these activities and doing them at least 3 times a week. Being kind to yourself, staying calm, keep thinking clear, keep doing things you enjoy, stay engaged with good people, keep your healthy routines, keep looking forward. Okay, I'll move on from there and I'll hand across to Simon for questions. Thank you very much.
Thanks so much, Nick, and another excellent presentation. I think it's amazing what we've been able to cover in such a short period of time, and I hope it's been useful to all of the people logged on. I'm sure it has been. There have been a number of questions that have come in, some of which I'm now going to feed back to you in the panel. I've already answered one around the need for ongoing vaccinations. And it also, I think, applies to Kaz's question, which was, if I've already had COVID, why do I need a vaccination? And the answer is, for either previous vaccinations or previous infections, they won't affect you against emerging strains. So in the same way, we have to have regular influenza vaccinations because the COVID virus mutates quickly. While COVID is in the community, we're probably going to need to have regular booster doses after primary. I'm going to go now through some of the questions and direct them to people on the panel. The first one I might direct to you, Janaki, if you're happy. It comes from Gavin, which says, any comments, please, on mandatory vaccination? This is quickly becoming an issue for workplaces, employers and employees. And I think this is another tension issue that we've alluded to before in terms of sort of rights of individuals versus rights of communities. Janaki.
Yeah, thanks. And it's quite a complex question in some ways and quite an easy question in other ways. I think it's worthwhile thinking about what the aims of vaccination are. And they're partly around keeping yourself safe, but also keeping people around you safe. And this is when we think about those compulsory components of the vaccination uptake. Remembering also that if we have really good uptake of vaccination, we don't need to have compulsory vaccination because our coverage will be high anyway. There are particular parts of the community that we've always had compulsory vaccination for particular events. We require abattoir workers to have Q fever vaccination. We require parts of our health workforce to have regular flu vaccination, TB vaccination, hepatitis B vaccination. So I think it is very much contextual. We need to think about the places. I think it was part of that phase 1AB rollout, the people who are most likely to be impacted by potentially being infected and most likely to then spread it to other communities, as well as those who are most likely to have their own health impacts from vaccination. So I think there will be particular parts of the community who will have mandatory vaccination. It is legal, there are precedents, and there are some parts of the community where it really will have some impact. But if we have really good high uptake across the community, it won't be as required in the more borderline communities.
Thanks very much for that, Janaki. Another question from Irene, but I imagine many people have the same question. Can I get the slides for the Nick Titov from Nick on practical skills? I've sent out a message saying that the webinar is being recorded, but we did talk about that beforehand. Nick, did you want to respond to that?
I'm happy to make those slides available. I think it might be easier if I make them available via MQ Health, and perhaps they can put those on the website, but there's another way. I'm happy to take that offline as well.
Thank you, Nick. We have a wonderful panel. What we don't have on the panel is an infectious disease specialist, and the question here from RBU83069 is very specific. The TGA has provisionally approved the Johnson & Johnson single-dose COVID vaccine, which is used widely, I understand, across Europe and the US. It's single-shot vaccine, unlike the ones currently available in Australia. Do we know why it's not being used in Australia, and will Australian states accept visitors and residents who've had this vaccine without significant isolation? I might throw that to you, Janaki, for if you know anything about it, but it is a very specific question, and any response we give now may actually change over time.
Thank you for that proviso, Simon. That's absolutely true. It could change over time.
That's right, because the status of all of the vaccines will be updated regularly.
Absolutely. And I think one of the things that is really going to be considered and will be talked about more widely, I think, in terms of the border control issue that you've discussed there, it's always been about what's been approved in Australia. That's going to become questioned. I think the World Health Organization will be talking about which vaccines around the world are approved rather than country by country, because as we open borders, there are going to be different countries who have different vaccination practices, and we need to know which ones will keep the individuals who are vaccinated safe and the ones that will keep the community at large safe as well. So not directly answering your question, but more this is a place that we're gaining more answers as we move forward.
And thank you, Janaki, for talking about borders. One of the things we haven't mentioned that's very relevant is that 25% of us in Australia have family overseas or were born overseas. And it's been a very trying and testing time for families who have been physically separated through the border requirements, and another contribution to some of the stress that Nick's been talking about. I have a last question here that it's again quite specific, and I might present it to you, Sanjyot, as a GP, because it's the sort of questions we get each day in practice. Do the present vaccines protect against the new MU variant of the COVID virus? And I guess it ties into those earlier questions of why do I have to have boosters?
Thanks, Simon. I mean, to date, the vaccines seem to be holding up well against, new variants, but it is a constant, the information is coming in all the time. So that's why we will, as you mentioned, have boosters most likely, and initially for the more vulnerable, but then it may be across the board. Everyone that's had one will then have another one in 2022. So I'm not sure I can specifically talk about that variant, but up to now, even for the Delta variant, which was different to the one that we had at the beginning of last year, that the vaccines do seem to be holding up quite well.
We're coming up to 1 o'clock, and it is important we finish on time. We've just had a question come in from Khan, which I'm going to answer as a GP, because I think it's very relevant of the sorts of questions that are out there in the community. My aunt has stage 4 colorectal cancer. should she get the vaccine? And the answer is that there are very, very, very few reasons not to have the vaccine. There are some specific contraindications, most of which relate to being allergic to some of the components of the vaccine, and they're all quite rare conditions. My feeling is that for someone like your aunt, who quite likely is going to be unwell and immunocompromised if she's having chemotherapy or other forms of therapy, absolutely we would recommend having the vaccine. It's not going to increase her risk of significant illness, and it may protect her from severe illness if she comes in contact with the virus. I'm going to leave it there. I'm sorry, there's one question still about 5 to 11-year-olds, and the answer to that, I think, is still very much watch this space. I suspect there will be announcements over the next month. And I thank all of the panel for the work they put into their presentations. It's a really hard ask to get somebody to talk about a very complex topic in only 15 minutes, and I think you've all done a wonderful job. Thank you for those who've organised from behind the scenes as well, and I hope it's been helpful to the members of our MQ community.